patient was treated successfully with IV penicillin. He was compliant with his antiretroviral therapy. And in the wake of the syphilitic uveitis, he did have some retinal pigment epithelial changes and visual field changes at long-term follow-up, but preserved his 20/20 visual acuity in the affected right eye. This is also another very characteristic syphilitic type of uveitis called syphilitic posterior placoid chorioretinopathy. And you can see in the posterior pole of this patient's affected right eye, the patient's visual acuity had declined to the finger counting level, but you can see this very well demarcated plaque. Again, this is posterior
wake
placoid
of the syphilitic uveitis, he did have some retinal pigment epithelial changes and visual field changes at long-term follow-up, but preserved his 20/20 visual acuity in the affected
in addition
right.
to infectious. But when you look at the OCT findings, these are distinct from the findings that I showed earlier, those superficial retinal precipitates. Instead, in this characteristic finding, you actually see that there are these very distinct outer retinal pigment epithelial excrescences. You can see that also the optic disc edema and the thickened nerve fiber layer within the posterior pole. And it's important to note that some of these patients actually are some of your most grateful patients after they're treated with IV penicillin. So let's move on now to our next polling question. We're going to switch gears to viral uveitis, and we're going to talk about acute retinal necrosis. So which of the following is highly sensitive? Which of the following tests is highly sensitive for the diagnosis of acute retinal necrosis? A chest X-ray, B, antibody testing for prior exposure to HSV1, HSV2, or VZV, C, PCR testing for VZV, HSV1 or 2, or CMV, or D, MRI of the brain and orbits. We'll give you a couple seconds to answer that question. Okay, fantastic. So again, the majority selected correctly. PCR testing for VZV, HSV1 and 2, or CMV. And this is a tricky one because there are a number of tests that can be used to evaluate patients for a history of both viral exposure and whether the virus is the etiologic agent. It turns out that chest X-ray we think of for other conditions, again, with pulmonary findings such as sarcoidosis and tuberculosis. Antibody testing is really indicative of prior exposure, so it can be helpful when it's negative because it shows that patients may not have been exposed, although there can be waning immunity over time. But PCR testing, we know, has sensitivity that approaches 90% for viral entities, especially with trusted laboratories. MRI of the brain and orbits can be a consideration, especially if patients have a history of potential encephalitis, either due to HSV1 or 2. Varicella zoster virus can also cause a central nervous system vasculopathy, but the correct choice is PCR testing, at least related to viral retinitis. This was a report from the American Academy of Ophthalmology in an ophthalmic technology assessment, which I had the opportunity to be a part of several years ago. And we assessed the evidence related to interventions for acute retinal necrosis. This included both diagnostic as well as therapeutics. And what a thorough assessment of the literature showed was that PCR turned out to be positive in anywhere between 80 to 100% of cases of acute retinal necrosis, depending on the clinical findings, which were often consistent with acute retinal necrosis and helped to identify predominantly VZV, HSV1 and 2, and CMV in rare occurrences. Both the aqueous humor and vitreous humor can be highly sensitive and specific. We also noted that using a combination of intravitreal antiviral therapy with either foscarnet and ganciclovir in conjunction with systemic antiviral therapy showed that the outcomes appeared to be superior to systemic antiviral therapies alone, although there have been very limited prospective or no prospective studies related to this. Most of these are in retrospective assessments. This is a case of a 45-year-old patient with no other medical comorbidities. You can see that this retinitis is found throughout the peripheral fundus, including these multifocal areas of retinal whitening. The vitreous is extremely hazy, and visual acuity had declined to the 20/100 level. With treatment with a combination of intravitreal antiviral therapy and systemic antiviral therapy, the visual acuity improved to the 20/60 range. And you can see the improvement of these multifocal lesions. This is both a combination of an infectious process as well as a severe inflammatory response that can affect the retinal vessels, sometimes with retinal ischemia as well. It's also very important to note that when we think about the possibility of acute retinal necrosis, that we really avoid corticosteroids if we think that viral etiology may be a possibility. These are some examples when corticosteroid is used before an appropriate diagnosis of viral retinitis. This is a patient who had a steroid dose pack with this diffuse retinitis. This is another individual who received an intravitreal dexamethasone injection and subsequently developed particularly severe disease with vitreous haze and multifocal retinal whitening. This is another patient who actually had a dose of IV solumedrol in the context of VZV retinitis, and this was, again, before a diagnosis had been properly ascertained. So you really want to avoid corticosteroid therapy if a viral uveitis and a viral retinitis in particular is being considered. Now, this is distinct from situations where a diagnosis has already been made and antiviral therapy is on board. In those cases, sometimes corticosteroid can be considered after appropriate antiviral therapy has been initiated. And there are differences with regards to timing of corticosteroid. Now, with regards to cytomegalovirus retinitis, this was largely associated with HIV/AIDS in the 1990s and early 2000s, before the widespread use of antiretroviral therapy. You can see this very characteristic brush fire retinitis with retinal whitening, also can be very hemorrhagic because of the damage to the vascular endothelial cells. But we're not seeing this quite as much in some settings where there is widespread use of antiretroviral therapy, but instead we're seeing CMV retinitis due to immunosuppression for other reasons. And so it's very important to keep on the radar in a number of situations. Some of these situations include collagen vascular disease, patients with collagen vascular disease who are on immunosuppressive therapy. We also want to think about this for patients who have had a solid organ or bone marrow transplant who are on long-term immunosuppression, and certainly individuals with a history of malignancy who have undergone recent chemotherapy or chemotherapy at large. This is a patient with a history of non-Hodgkin's lymphoma who was status post rituximab with an anti-CD20. This is a medication that targets B cells and immunosuppresses the patient. The patient was also on bendamustine, which is an alkylating agent. And in the setting of significant systemic immunosuppression, you can see that this cytomegalovirus retinitis has developed. There are these granular areas of retinal whitening within the retinal periphery. There are also these very, very subtle retinal pigment epithelial alterations and vascular sheathing along the retinal vessels. And this is a photo montage that, again, illustrates the cytomegalovirus retinitis that can be distinct from what we see in the setting of HIV/AIDS. This is CMV retinitis in the setting of other causes of immunosuppression. With regards to management, this is another patient who is a 71-year-old individual who had a renal transplant from a CMV positive donor, who was also on a number of immunosuppressive medications. We diagnosed CMV retinitis with qualitative PCR to establish that the aqueous humor did indeed have CMV DNA, and we could also use quantitative PCR to follow the disease over time. Some of the strategies for treatment include oral valganciclovir in conjunction, sometimes with intravitreal antiviral, to suppress viral replication. Other patients sometimes will need to be hospitalized for IV foscarnet or IV ganciclovir, particularly if they have bilateral or very severe disease. It's important to note that the ganciclovir implant, which we previously were able to use for CMV retinitis, is no longer available. And at long-term follow-up, patients who are systemically immunosuppressed sometimes will need chronic valganciclovir therapy, but resistance mutations to ganciclovir and foscarnet can develop in the context of chronic valganciclovir prophylaxis. And these can be screened with a variety of techniques to look for various drug mutations. Now, moving on to toxoplasmosis. which is a leading cause of infectious uveitis worldwide. This is a more atypical case. This is a 59-year-old patient who underwent a trabeculectomy, bleb needling, and mitomycin with subtenons, triamcinolone, acetonide. You can see the deposit here, but she developed an anterior and intermediate uveitis in the affected left eye. You can see this diffuse vitreous haze. But PCR, interestingly, for VZV, HSV, CMV, and toxoplasmosis turned out to be negative from her aqueous humor. She subsequently underwent a diagnostic pars plana vitrectomy, and we were able to identify these toxoplasmosis bradiozoites. You can see these in the cysts within the vitreous cavity to establish a diagnosis of toxoplasmosis. And I need to credit the amazing pathologist, Dr. Hans Gross-Nikolaus, for identifying toxoplasmosis in this very challenging case. So this is a more typical lesion. We see an area of choroidal scarring with a focus of retinitis. And we actually looked at the evidence for toxoplasmosis therapy. And this is also another report by the American Academy of Ophthalmology. And on a review of 8 randomized controlled studies, interestingly, none of the studies showed that the routine use of antibiotic or steroid favorably affected visual outcomes or reduced the lesion size. And this was at long-term follow-up. And so what this doesn't necessarily account for is the importance of symptom management and the potentially expediting disease. But we'll consider anti-toxoplasmosis medications for optic nerve involvement, macular involvement, and certainly in individuals who are immunosuppressed. As I mentioned before, with regards to antibiotic therapy at long-term follow-up, the visual outcomes may not necessarily differ, but oftentimes, particularly when patients are symptomatic or if there's posterior segment involvement, as seen in this patient, then we will opt for toxoplasmosis therapy. Now, tuberculosis is also on the rise from the standpoint of a public health and global health disease process of great interest. Primary ocular tuberculosis is actually limited to conjunctival and corneal disease. You can see these tubercles actually on the ocular surface, and this is in the setting of a primary infection. But what we see oftentimes is a secondary ocular tuberculosis, where the acid-fast bacilli will reach the choroid via the bloodstream after initial infection of the lung. The most common manifestation is choroiditis. You can see these large choroidal tubercles actually within the choroid in this area of high oxygen tension. This is an individual. She's a young pediatric age patient that I saw who unfortunately already had scarring in her right eye of unclear consequence. We thought that she had some posterior uveitis syndrome, but it turns out that she actually had tuberculosis exposure previously. And you can see in the fundus photo of her newly affected left eye that she has also optic disc edema, as well as these choroidal tubercles. She ended up being quantiferon TB gold positive, indicative of prior TB exposure. And you can see these multiple hyperfluorescence dots with this leakage and pooling in this subretinal space, and the OCT shows a choroidal elevation that's indicative of this choroidal lesion. Our colleagues from Southeast Asia and also Latin America have nicely described this other syndrome called presumed tuberculosis-associated serpiginous-like choroiditis. And this is a condition where there's some exposure to tuberculosis, but diffuse retinal pigment epithelial change is actually observed. It can also look like serpiginous choroiditis. And so in anybody who has an appearance that looks like serpiginous, very important to think about the possibility of TB exposure and treatment as indicated. This is another manifestation of tuberculosis. This is tuberculosis-associated retinal vasculitis. This was a young girl from Southeast Asia who has this very subtle retinal vasculitis in the right eye, which was affected. She was 20/20 in this eye. In her left eye, which was a very highly symptomatic eye, visual acuity had declined to the finger counting level at 5 feet. You can see these diffuse exudates within the posterior pole, and also a peripheral tractional retinal detachment in the setting of severe vasculitis. This is thought to be an immunologic reaction in the setting of prior AFB exposure. This was first described by Henry Eales, Dr. Henry Eales in the 19th century. And this is characterized by venous inflammation, retinal neovascularization, and is thought to be potentially due to a hypersensitivity reaction to mycobacterial protein. And you can see these retinal vascular sheathing changes that were similar to our patient that I showed on the past slide. So now we're going to shift gears to some of the emerging infectious diseases. And this is our third polling question. This is on Mpox eye disease, formerly known as monkeypox. Which of the following is the most common manifestation of Mpox? A, orbital apex syndrome, B, keratitis and conjunctivitis, C, endophthalmitis, or D, sixth nerve palsy. Okay, so how did we do? So again, the majority of the attendees answered correctly, answering keratitis or conjunctivitis. Interestingly, there have been reports of hypopyon, which have been rare, and so this is not untrue. But we asked the most common manifestation of Mpox, and certainly we're learning more and more about this disease condition. So the correct answer is keratitis conjunctivitis. And so as we think about the most common manifestation, this is what we need to be on the lookout for. And while this is not traditionally thought of as a uveitis, I did want to mention this disease state because of its importance from a public health perspective. And as we enter into this second part of this webinar, what I wanted to mention is the eye really represents a unique window to these emerging infectious diseases. Our group and others have studied Ebola virus disease, Mpox, as on the last polling question, can lead to a severe keratitis and conjunctivitis, sometimes with intraocular involvement. And more recently, our colleagues from the CDC have documented severe conjunctivitis in individuals who are affected or infected with highly pathogenic avian influenza or H5N1. And there are a number of vector-borne infectious diseases that can lead to ocular findings as well. Dengue can lead to a maculopathy or a foveolitis. This has been well characterized from our colleagues both in Latin America and in Southeast Asia, as well as around the world. Chikungunya can lead to a wide array of ocular inflammatory findings, including keratitis, neuroretinitis. There was a report on chikungunya that was positive in the anterior chamber out of India in a patient with uveitis. And Zika virus can also lead to both anterior and posterior uveitis, although the more common manifestations are related to infants that were born to Zika-infected mothers. There's some really outstanding work from Dr. Camila Ventura from the Altino Ventura Foundation that showed that infants who were born to Zika virus-infected mothers could have chorioretinal abnormalities, but ocular inflammation has been reported and should be considered in the proper clinical setting. Now, what is Mpox? So Mpox was declared a WHO public health emergency of international concern on 2 occasions, both in 2022 and 2024, and that second public health emergency since has ceased. But it turns out that Mpox still remains a African CDC public health emergency of continental security because of the sheer magnitude and number of cases that are still ongoing in different countries within Africa. It's important to remember that this is a systemic syndrome. Patients can develop a blistering rash that can last for several weeks. Patients can have fever, headaches, swollen lymph nodes. You can see this affected individual that was on the United Nations website. But Mpox actually may be more virulent in individuals who are immunosuppressed, particularly individuals who are HIV positive. Some of the risk factors include individuals, men having sex with men, high-risk sexual behavior, and also recent contact with Mpox patients. Well, why is this a concern and a finding that we're speaking to from an ophthalmology perspective? Well, it turns out there are a number of ophthalmic complications of Mpox. These can include periocular umbilicated lesions, conjunctivitis, as shown in this image, as well as keratitis, which I previously showed. There are also rarer reports of uveitis and hypopyon. And it's also important from a healthcare provider standpoint that to know that Mpox has also been identified in the tear film through PCR and sequencing, and also late recurrence of mpox. PCR positivity has been reported in individuals who have ophthalmic complications associated with mpox. This is a report from some of our colleagues from the Democratic Republic of Congo, and it turns out that this disease entity has been that ocular manifestations of mpox can be found in association with viral persistence within the ocular surface. This is a report from Finnemore et al., and they were able to identify replicating monkeypox virus in at least one sample in the patients that they evaluated up to 150 days after their first skin lesion. One of the HIV positive patients was the one who actually had the latest positive result at about 5 months after the acute infection. So it's just important to note, particularly in the context of ocular manifestations, to be cautious and also use the proper personal protective equipment if there's suspicion of mpox. In their series, they looked at cycling threshold values, and these range from 24 to 35. You'll recall that the higher the cycling threshold, the lower the viral load. But anything less than a cycling threshold of 33, they were able to identify a positive culture. So above 33, it was less likely that it was culture positive, but instead that they were thought to have residual mpox DNA that was not necessarily replication competent. This is a very well-characterized case, again, from the UCSF Proctor Foundation. This is an individual who was actually HIV negative, who developed scleritis, keratitis, and severe uveitis. And they used deep sequencing to show that mpox RNA could also be identified within the aqueous humor. And lastly, this is a report from Lancet Infectious Disease. This is an individual who had persistent mpox ocular involvement for about 8 months, with several episodes where mpox virus DNA was able to be identified from the ocular surface and ultimately required several different antiviral strategies to eradicate the disease. So this can be very difficult to eradicate and very important to just have on the radar with regards to the various treatments that are available. These can include systemic antiviral therapies. Topical therapies, trifluridine has been utilized for the successful treatment of mpox-associated keratitis, as well as topical antibiotics to prevent bacterial superinfection. But very important from a preventive strategy standpoint is ensuring that the patient and the family have frequent hand washing, hand hygiene, and certainly avoidance of eye rubbing. For the healthcare provider and ophthalmologist, very important that we have infection prevention and control precautions in place with strict equipment disinfection protocols. The PPE is very similar and actually is the same as the COVID-19 PPE, including a gown, gloves, N95 respirator, and eye protection as well. And the other disease I wanted to talk about a little bit more in more detail was Ebola. And Ebola's legacy, many of you familiar with, has left many patients, unfortunately, with severe uveitis. This was an article from a New York Times reporter who documented the story of a very nice young girl. Her name is Aminata Kanta, and the story was, again, well publicized. But Aminata Kanta was an Ebola survivor who developed severe uveitis and later on developed a cataract in the context of untreated uveitis because of significant challenges with access in her country of Sierra Leone. And we've had the privilege of taking care of Aminata for a number of years for her disease state and to understand this condition further. This was a United States healthcare worker, images of a United States healthcare worker whom we treated, who developed Ebola-associated panuveitis associated with iris heterochromia. And interestingly, this United States healthcare worker was an Ebola survivor who was taking care of Ebola patients within Sierra Leone, was repatriated to the United States and survived Ebola. And he developed uveitis around 3 months after his acute episode of Ebola. This was after Ebola virus had actually cleared his bloodstream. He developed a severe anterior uveitis progressing to a scleritis, ultimately a severe inflammatory reaction with a hypopion, intermediate uveitis, and posterior and panuveitis with this iris heterochromia that was seen here. Fortunately, with a variety of antiviral therapies, as well as corticosteroids, both local and systemic, he was able to be treated for this condition. But in this context, we identified that the patient had Ebola virus within his aqueous humor after he had cleared his bloodstream. Again, knowing that the eye is an immune sanctuary site where viruses can persist, not just Ebola, but also other viruses and pathogens, as I've previously described. And this was the report in the New England Journal of Medicine and the New York Times. But we found later within West Africa from other individuals who had a history of Ebola, these are Ebola survivors, that uveitis was also very prominent. Over 20% of Ebola survivors were also identified to have signs of uveitis, with a significant majority with visual acuity impairment. Unfortunately, a number of these patients also met criteria for WHO criteria for blindness of 2400 or worse. And some of these reasons include causes of blindness, such as neovascular glaucoma, ptysis bulbi from untreated uveitis or difficulty with access, and also uveitic cataract, which can develop again in the context of untreated inflammation. So these are problems that we're continuing to understand and treat within Sierra Leone, and also with efforts in the Democratic Republic of the Congo as well. So the WHO actually has a list of pathogens that are considered highly likely to cause outbreaks in the future. And it turns out that some of these high priority pathogens can also lead to ophthalmic manifestations. We've talked about Ebola virus. Lassa fever virus is also a virus that we've continued to look at that has some ophthalmic findings in limited numbers. Nipah virus is a highly lethal paramyxovirus that's been identified in Southeast Asia. And there's been a rare report of a central retinal artery occlusion, and Rift Valley fever, which can actually lead to aborted fetuses in cattle. This is a hemorrhagic fever seen in domestic animals. And patients will develop severe complications, including very devastating neurologic findings, and ultimately can develop retinitis and uveitis as well. And so we see this in various parts of Eastern Africa, as well as some areas in North Africa as well. And the other major concept that I just wanted to briefly touch on is this One Health approach to infectious uveitis and eye disease in general. So what is One Health? So it turns out that One Health is a collaborative, multi-sectorial, and transdisciplinary approach that works at multiple levels, really bringing together this interconnection between human disease, animals, and our shared environment, notably very important for optimizing outcomes within patients and all stakeholders who are involved. And how is this relevant? Well, it certainly is relevant with the obvious connections related to zoonotic disease, but also a number of other conditions as well. We've talked about Ebola, SARS-CoV-2, toxoplasmosis, toxocariasis can have their individual ophthalmic manifestations. We haven't talked about Bartonella, but certainly can have implications related to both animal and human health as we think about our shared environments. There's a lot here, but what I wanted to point out as we think about these One Health considerations, that it really does bridge human, animal, and environmental health, both related to animals and environments that humans may encroach on with regards to different urbanization measures, but also important as we think about the other factors that contribute to risk factors for disease, including food security, social cultural context in the different areas, especially given the global nature of this webinar that we are a part of today. And this is a busy slide, but what I wanted to mention again, as we think about all of these diseases that we chatted about, whether it's vector-borne illness such as chikungunya, these emerging pathogens like Nipah, certainly others like Ebola and herpes simplex virus. It just turns out that it's important to bring all of these aspects together when we're thinking about infectious uveitis. And the infectious uveitis syndrome landscape, as we see here, these are some of the more common entities that we see worldwide, but the landscape is really changing, including the importance of emerging pathogens, but also recognizing these diseases such as syphilis and tuberculosis, which have very high public health impact, not neglecting other conditions like toxoplasmosis, which are, again, leading causes of infectious uveitis worldwide. And I'll just summarize that we, again, have covered a broad array of uveitis that may be observed with a number of pathogens, including bacterial, viral, and parasitic, highly relevant for patients in the public. We've talked about emerging pathogens, including Mpox, Ebola, and vector-borne illness that can be causes of ophthalmic disease, including uveitis, and certainly the future development of diagnostics and multidisciplinary One Health approaches will be extremely important for management of patients with sight-threatening eye disease. I'd like to thank all of the members of our team who contributed to our efforts both within the United States and in Africa, and also to the entire Orbis CyberSight team for the opportunity to be with you today. Thank you very much. And I think now we're going to switch over to the Q&A section. So I have a question from Dr. Shekhar on a management protocol for viral uveitis. Very important question as we think about rubella and HSV1. As we think about HSV1, for instance, it involves really a combination of both systemic and local intravitreal antiviral therapies. The way I approach this is I think about the patient's age and whether they can tolerate a course of antiviral therapy at the dose that's required for their renal function. If the patient is a young patient or a younger patient with responding to therapy, and in individuals who have bilateral disease, or if it's not uncommon to have one patient who has had a history of eye disease in one eye and is subsequently monocular and needs antiviral therapy for their other eye. Some of these patients I'll actually consider admitting to the hospital for an evaluation with our infectious disease colleagues and also management so that they can monitor their systemic measures of kidney function. Now, rubella virus is challenging because there's no specific antiviral therapy that is commercially available for rubella, so I'll use topical corticosteroids to treat the inflammation and monitor them very closely. They can be susceptible to elevated intraocular pressure, and so ocular hypertension needs to be managed very closely as well. Another question from Dr. Vasquez-Ortiz, excellent question related to prednisolone and starting dose. And this really depends on the level of inflammation that the patient demonstrates in their anterior chamber and also within their anterior vitreous. In individuals who have a hypopian uveitis, and sometimes I'll dose at every 2 hours or even every 1 hour if I don't, and we'll really tailor this to whether I suspect there's any suspicion for an infection. If there's any suspicion for infection, then I'll usually use a diagnostic test, and I'll give an example. If a patient, for instance, has a potential for chronic endophthalmitis, which we'll also see, then sometimes these patients will also benefit from a tap and inject, so we can do a culture as well as injection of antibiotics. And in this setting, then I'll feel more comfortable going up on the topical corticosteroid dosage. In patients perhaps with milder disease, then every 4 hours or 4 times a day can be utilized. But I really tailor this to the level of inflammation within the anterior chamber and also think about the possibility of an infectious process. The next question that I have is from Nepal. Welcome, and it's great to see Dr. Basnet on the call. How can secondary glaucoma, macular edema, and retinal detachment be avoided and treated in infectious cases? So these are all very important complications. And one of the challenges that we see in various regions of the world, depending on how quickly the patient comes to a doctor, is that sometimes there can be challenges because of the number of secondary complications that have already developed by the time they're seeing the ophthalmologist. And so I think that it really starts at the community health level in terms of understanding when a patient needs to be referred in. But with regards to avoidance and treatment, I'll focus on the treatment side, is that at least when we think about secondary glaucoma, there are multiple factors. We start with topical ocular hypotensive medications. Uveitis patients can also be susceptible to secondary angle closure mechanisms that don't necessarily respond to to topical agents alone. Some of these patients will end up needing surgical therapies as well. And we know that trabeculectomies have a high rate of failure. So in these situations, tube shunt or other types of filters can be beneficial. Macular edema can be treated, and it really depends on their phakic status. If they're aphakic or pseudophakic, then sometimes topical corticosteroids, either with prednisolone or difluprednate, can be utilized. But I'm very, very cautious in these patients with regards to local corticosteroid injections. And I even lean towards avoiding local corticosteroid injections completely if an infectious uveitis is a consideration, because you can go from a moderate level of visual acuity loss to severe blindness in patients who are treated with local steroid injections. And with regards to retinal detachment, these are very complex detachments, but in terms of treatment, these require vitreoretinal surgical intervention, sometimes in conjunction with membrane peeling techniques and silicone oil installation for long-term tamponade. I have another question from Dr. Keshavarzi on how much sample volume in the AC and vitreous tap, and how is the way for media transfer? Fantastic question as we think about the amount of volume that's needed for various PCR techniques. And so I think this really depends on the laboratory that you're working with. The example that I'll give you is that, at least in our laboratory, it requires about 50 microliters per PCR test. And so the sample volume, if we wanted to do varicella zoster, herpes simplex, and toxoplasmosis, is about 150 microliters. I'm cautious in younger patients with a vitreous tap because the vitreous is still formed and gelatinous and not yet liquefied. Although in patients who are older, over 60 or 70 years of age, they may have more liquefied vitreous, and it can be safer to perform a vitreous tap. If I'm concerned about whether I'll have enough sample, or particularly if I have a high index suspicion despite a negative clinical test, then sometimes I will recommend a diagnostic vitrectomy to do a higher volume vitrectomy specimen. And how is the way for media transferred? In general, with regards to PCR testing, this can be transferred and can be stably transferred at room temperature. And we don't use, at least in our experience, we don't use any specific media for PCR. On the other hand, if you're looking for a condition like vitreoretinal lymphoma, sometimes media transferred is required, and the specific media will depend on the laboratory that you're working with. Sometimes some of the pathologists will prefer RPMI, others will prefer direct transfer on ice. And so the principle that I would recommend is touching base with the laboratory, whether it's the cytology lab, whether it's the ophthalmic pathology lab, or whether it's the molecular lab, to determine if they have a preference. The one other aspect of ocular fluid, because these are limited volumes, is that sometimes they'll ask if the volume, say for instance, you get a volume of 50 to 75 microliters and you want additional testing. There are protocols that have been developed where they can dilute up the specimen to the desired volume to actually, again, isolate the molecular material, the DNA or the RNA, to run the testing. And so that's a discussion that can be developed and discussed with the laboratory. Okay, I have a next question. How to treat a case of idiopathic panophthalmitis with vitreous hemorrhage with no perception to light? This is a complex, certainly a complex case. The area of history that I think is particularly concerning is the 5-day history of altered sensorium. If there is neuroimaging that's available, I would highly recommend that. I would be concerned about the possibility this could be indicative of an endogenous process. And so understanding their systemic condition further, understanding whether they have fevers, febrile illness, blood cultures, ensuring that there isn't a life-threatening process, I think would be very important. Certainly, if it's isolated to the eye, I think that that's a different situation. But with an altered sensorium, I think that a full systemic workup would be indicated in conjunction with healthcare providers at the hospital. Sometimes they can be on the internal medicine or the primary care side, but that would need a systemic workup to ensure that there isn't any other condition that's ongoing. But very difficult question and hard to know without additional information, but thank you for that question. Okay, so next question, this is a quick one on intravitreal antiviral injections. Foscarnet can be dosed at either 2.4 milligrams and 0.1 cc's or 1.2 milligrams and 0.05 cc's. This can actually be withdrawn actually directly from the bottle and compounded by the pharmacy. With regards to ganciclovir injections, 2 to 4, typically 2 milligrams and 0.1 cc's. I have a question from Dr. Ng, infectious disease physician from Malaysia. Welcome, Kevin. The question is the typical treatment duration for infectious uveitis, and is there an objective way to assess the response, or is this based on PCR viral load of some viral causes? Really fantastic question. So because of the risk associated with periodic and sequential anterior chamber taps, this is not something that we'll necessarily do unless the patient doesn't appear to be responding to their clinical therapy. The most typical duration I find, again, it just really varies from patient to patient, but I think that being more aggressive or early on in the first 2 to 3 weeks can be extremely helpful with high-dose systemic antiviral therapy. And with regards to assessing the response to treatment, this is where I think that photographs and also clinical evaluations can come into play. As I showed from some of my other slides, when you have these borders of retinitis that become more well demarcated and more consolidated, this is one clinical objective response to adequate or improvement in their treatment. Now, what is interesting is that these patients can also develop inflammation and post infectious inflammatory response. So this also needs to be monitored, sometimes in conjunction with anti-inflammatory therapy. There are some situations where I will follow the quantitative PCR. The example that I'll give you is a patient that I showed from the slide deck of a patient with CMV retinitis. And this patient was particularly difficult to treat because of his immunosuppressed status, and the CMV retinitis wasn't turning around very quickly. In addition, because CMV can also affect the retinal vessels, the patient would drop down to an inability to see light each time we did an intravitreal injection. And because of that, we performed an anterior chamber paracentesis to relieve the pressure, and we also sent this off for quantitative PCR. And with this quantitative PCR, we were able to assess with quantitative real-time PCR the levels of CMV DNA, so we could see the trend trending downward with adequate therapy over time. And so that's one situation where I will think about repeating the PCR, but this is certainly can be done in conjunction with the laboratory. A question from Afrin K. Thank you, Dr. Afrin, for attending. How do you find that the patient is infected by mpox, or is this just by inspection? And I think that clinical inspection and also history are very important. Patients also sometimes can have risk factors, as I mentioned before, if they've had high-risk sexual contacts or if they've had any family members with a history of mpox. The historical factors can be important. Also important to think about the current epidemiology of whichever country the patient is being evaluated. These can have characteristic lesions, including these umbilicated mpox or pox-like lesions. They can be mild, they can be widespread, or they can be also in different locations, and they can also show evidence of scarring. So these are some areas that need to be considered. As we think about the ophthalmic manifestations, again, these are primarily within the conjunctiva and also the cornea. So it is important to ask some of these factors historically as well in conjunction with the clinical findings. And if there is any suspicion, particularly with risk factors, then again, it's important to recall your personal protective equipment, very similar to what, or the same as what we use for COVID-19. Okay, question from anonymous attendee. Thank you for attending. On toxoplasmosis, how many cases of toxoplasmosis require a posterior subtenon's steroid injection? So I would say that in general, I will not inject posterior subtenon's corticosteroid for toxoplasmosis. I showed that very severe case of toxoplasmosis, and I have other very severe cases of toxoplasmosis. Interestingly, there is, with regards to viral uveitis, there's some debate as to whether injection corticosteroids can be utilized. I tend to stay away from local corticosteroid injections in both contexts, but particularly with toxoplasmosis, I've seen severe cases where you can actually get a diffuse toxoplasmosis retinitis that actually can get basically wall-to-wall wipeout of retinitis with toxoplasmosis chororetinitis. And so I will avoid posterior subtenon's steroid injection with toxoplasmosis. Good question from Dr. Sayed. Why is PCR of the aqueous or vitreous humor preferred over serum antibody testing in acute retinal necrosis? Serum antibody testing shows evidence of exposure. So if individuals have an IgG that's positive for HSV1 or HSV2 or VZV, that just shows that they've had prior infection. And when you look at serologies of individuals over time, a high proportion of individuals in the general population will be positive. PCR of the aqueous humor is very highly sensitive for detection of virus within the aqueous and vitreous humor, and this is thus preferred. The one situation where serum antibody testing can be very helpful are in situations where say, for instance, your HSV1 and HSV2 are negative. In this situation, it would be very unlikely that the patient had an HSV1 or HSV2 viral retinitis if their serum is negative, because that means that they have not had exposure to HSV1 and HSV2, which are the most common causes of alpha herpes, HSV-related acute retinal necrosis. Okay, so one question from Somalia, from Dr. Hussein. Thank you for your for attending from Somalia, and also your fantastic question. When should a patient with uveitis seek urgent medical care? I think that patients with uveitis who certainly should be seeking ophthalmic care, but particularly if there are systemic symptoms or some context for medical care, these are situations where medical care should be sought. I think over time, what I've done in my clinical practice is that I've erred towards having patients seek medical care if there's any untoward finding that we can't explain. So unusual rashes, pulmonary symptoms, respiratory symptoms, fevers, weight loss that is unanticipated or unintended. These are some situations that medical care should be sought. Now, urgent medical care is a different question, but I think that it's important because some of these patients can develop severe disease and systemic disease in the context of uveitis. And I'll give you an example. I had a patient who had a history of HSV1 associated acute retinal necrosis who actually developed encephalitis. In this situation, urgent medical care was required, and the patient actually ended up requiring ICU admission. We had another patient with varicella-zoster virus associated acute hypertensive anterior uveitis with weight loss, and this patient ended up developing a CNS, a central nervous system vasculopathy, in the context of her varicella-zoster virus infection. So again, just to emphasize, if there are other additional systemic symptoms, if there's acute findings, sometimes patients with a known diagnosis of lymphoma, for instance, if they have acute vision loss, this would be a situation where urgent care would be needed. Okay, Dr. Memon, Dr. Ronak Memon, thank you for attending. What is the time duration of anti-tuberculosis therapy and ocular tuberculosis? This is something that I'll manage in conjunction with the infectious disease physician according to infectious disease guidance for anti-tuberculosis therapy, and also taking into account whether there is any consideration for drug-resistant TB. And so this actually varies from infectious disease physician to infectious disease physician, depending on whether the patient has an exposure or active TB. And in cases, what I've seen from my colleagues from Southeast Asia, from India and Pakistan, that they'll get a full course of anti-tuberculosis therapy. I've seen some infectious disease physicians lean towards using isoniazid if we think that there's an exposure, but not active tuberculosis per se. So there can be differences of opinion with regards to infectious disease approaches. I lean towards a treatment course if infectious disease is on board, but because of the toxicities that can be associated with treatment of ocular TB, I do like to engage our infectious disease colleagues with regards to therapies because of the side effects and also the monitoring. We have a question from Dr. Fatima. Thank you for attending. Is topical prednisolone effective in intermediate uveitis? Great question. I think that this has been a question that's come up before, and we do see in some situations that in cases of more mild or milder uveitis, that topical prednisolone may be effective to quiet some of the ciliary body inflammation where we believe this is coming from. This is probably more effective in individuals who are either aphakic or pseudophakic. In patients who are phakic, they may not benefit as much, particularly if they have moderate to severe disease. And what we found is that when you have intermediate uveitis with cystoid macular edema, this doesn't appear to be as effective. Now, that being said, in terms of just thinking about the evaluation, once a full workup has been performed and you feel comfortable moving forward with at least some topical corticosteroid on board, I do think that it's reasonable to have some topical corticosteroid on board, watching for side effects such as ocular hypertension and monitoring the response, as I have had patients do well with topical prednisolone, but these are mainly the milder cases as opposed to the moderate to severe cases. We have a great question from Nigeria, Dr. Abubakar. Thank you very much for attending. Can you explain how the One Health framework integrates human health, animal health, and environmental health to address the emergent transmission of infectious diseases? And what specific strategies are recommending for managing risk factors? So this is a very, very important question. And I think that it's perhaps best described by thinking about the examples, maybe one of the examples or one or two of the examples that we talked about. We didn't talk too much about West Nile virus, but I did show one image that West Nile virus, it turns out, can lead to a distinct chororetinitis. And when we think about the roles of the environment, climate change, and also the encroachment of humans on animal populations, it's important to think about these factors. And also with climate, we certainly have changes within mosquito-borne illness as well. And so I think it's important to engage all the different stakeholders involved to get a full understanding of vectors that may be implicated, as well as understanding the epidemiology from a mosquito population perspective, and also understanding our environment. And that's just one example. Other example that I'll give you is as we think about Mpox, again, formerly known as monkeypox, thought to be, there are two clades that have been defined with different subclades, but I'll focus on the clades. There's clade 1, which is found in Central Africa, largely thought to be primarily due to zoonotic transmission in different parts of Democratic Republic of Congo. And it turns out that in the number of the areas where there's exposure, there are also other factors that are at play, including factors such as poverty, socioeconomic factors, potentially the role of nutrition, and the role of potential exposure, both from animal to human, and such. And so, as we think about these different diseases, it's important to think about the various risk factors and how we approach our understanding of disease, and also how various genomes may be identified both from an animal health perspective and a human health perspective that can intersect to think about this ecosystem more broadly. But very important question as we think about addressing each factor, where it's related to humans, animal, or environmental health, to think about these uveitis syndromes not in isolation, but as part of a larger system. But very important for follow-up, and I think that we'll see more about One Health approaches to infectious uveitis in the future. Question from Dr. Nabutambo. Thank you very much for joining. Does uveitis only affect immunocompromised patients? A very important question. Uveitis can affect both immunocompromised and immune-competent patients. And so it's important to think about the different phenotypes that may present in individuals who are immunocompromised versus in individuals who are immune competent. And one of the examples, probably one of the key examples that I showed, is related to HIV AIDS, where in the setting of immunocompromise, you can get a very severe CMV retinitis. You can also get a CMV retinitis in individuals who are immune compromised from a number of chemotherapeutic agents as well. But you can also develop uveitis in individuals who are immune competent as well. A number of patients who we saw who had acute retinal necrosis had no known history of immune compromise. Now, what's also interesting when we think about acute retinal necrosis, there's another condition, progressive outer retinal necrosis, which we see with varicella zoster virus. This can lead to bilateral severe retinitis. This was first described in the setting of HIV AIDS. And essentially, this is acute retinal necrosis in individuals who have severe immunocompromise. And the phenotype can be more devastating and rapidly progressive, leading to blindness, and needs very aggressive treatment. So important to think about the disease phenotype. And on the therapy side, also very important to think about the possibility of more aggressive therapy to address not just the infectious disease process, but also to address the underlying cause of immunocompromise as well. Question from Dr. Al-Zafri. Thank you for attending. What gaps exist in the evidence related to intravitreal injections in infectious uveitis? Which areas require future clinical trials? Fantastic question. As I mentioned before, we do have some statements from the American Academy of Ophthalmology that describe a measured approach to understanding the literature. This is a systematic evaluation of the literature. But when we looked at the literature, the vast majority of reports were limited, in the fact that they were retrospective series as opposed to prospective clinical trials. And so I do believe that a prospective clinical trial is certainly needed for herpetic viral retinitis. I think that there are clinical trials that are also needed for mpox, given the magnitude of the disease. As we think about other infectious uveitis syndromes, again, of substantial public health impact, including toxoplasmosis, there have been clinical trials that have been performed for toxoplasmosis, but it's also important to think about all of these disease syndromes and the importance of rigorous evidence that's prospectively developed to ask the right questions and be able to provide answers that can be satisfactory for our patient care. Okay, and then I've got a question from Dr. Mohammed Isawi. Hope I'm pronouncing your name correctly. Thank you very much for attending. When should empiric antimicrobial therapy be initiated in suspected infectious uveitis prior to etiologic confirmation? Fantastic question. I think that this depends on the clinical presentation and also the potential for vision loss. And when empiric, I'm going to talk a little bit about, again, therapy before an etiologic diagnosis has been made. And so in cases of viral uveitis, in these situations, we'll go ahead and initiate treatment prior to PCR confirmation. And the clinical phenotype can be very, very distinct. And in these situations, we will proceed with empiric therapy even before PCR diagnosis has been made. Very similarly for endophthalmitis thought to be potential bacterial, that we'll perform a tap and inject with oral fluoroquinolone because of its very high penetration to the vitreous cavity. And this is very helpful, again, to get the antibiotics on board, again, prior to etiologic confirmation. And interestingly, because cultures can oftentimes be negative in the setting of presumed infectious endophthalmitis, it is important to go ahead and get the antimicrobial therapy on board. So if your clinical suspicion is high, particularly with the potential for vision loss, then I think it is very reasonable to proceed with empiric antimicrobial therapy. Again, every situation is different, but can be very helpful to have the antimicrobial therapy on board as the laboratory tests are cooking. I have a question on any differences in the management of progressive outer retinal necrosis versus acute retinal necrosis. In these situations, I mentioned this very briefly before, but I will be very aggressive in the treatment of progressive outer retinal necrosis. These patients will sometimes end up being, or oftentimes end up being admitted for IV antiviral therapies. In addition, if they're not responsive to therapy, I will consider combination intravitreal antivirals with both foscarnet and ganciclovir. I am cautious about elevated intraocular pressure because the patients can be ischemic, and these patients sometimes will require an anterior chamber tap to avoid occlusion of the central retinal artery. Acute retinal necrosis patients, if they live close by or not too far away, then we'll sometimes manage as and more frequently now than when I was in training, that these patients can sometimes be managed as an outpatient. But progressive outer retinal necrosis patients, because the context sometimes can be in the setting of severe immunosuppression, I'll oftentimes care for these patients in conjunction with our infectious disease physicians. And I'm going to answer Dr. Widyastudi on toxoplasmosis uveitis before we close. And again, thank you for the question. Thank you for all the attendees. So the question is, do you think we need to do serologic testing to confirm toxoplasmosis uveitis, or is it enough based on clinical signs? I've done some work with our colleagues in Latin America and also in Western Africa, and the volume of toxoplasmosis that is seen in various parts of the world is so high that the pretest probability and the clinical suspicion is very high, that in some situations, I'm not sure that serologic testing actually would change the indication to treat toxoplasmosis uveitis. I think that if there is uncertainty about whether the patient has had toxoplasmosis exposure, I think that serologic testing can be particularly helpful if negative, as this can potentially help us lower this toxoplasmosis uveitis on the differential diagnosis. But in the setting of characteristic clinical signs, including choroidal scarring with an adjacent focus of retinitis, I think that it's sufficient likely to treat on that basis with a therapy of choice for the region and also the available medications. Oftentimes, this is with double strength Bactrim, again, in the absence of a sulfa allergy. Later on with corticosteroid. But I ensure that the antimicrobial, the anti-toxoplasmosis therapy extends out further along than the corticosteroid, because we want to make sure that the patients are not on corticosteroid by itself in the absence of appropriate anti-parasitic coverage. So again, I want to thank the Orbis CyberSight team for the opportunity to be with all of you this morning. Thank you again, and I apologize I wasn't able to get to all of the fantastic questions, but we'll look forward to further sessions, hopefully of uveitis in the future. And again, I want to wish all of you a wonderful holiday season, as this is the last CyberSight webinar for the year, and greatly appreciate everybody's time and attention. Thank you so much again. Take care.